if they're acidotic, alkalotic. Okay? We don't necessarily need serum electrolytes post-op. And when I say post-op, this is immediately post-op in the post-op area. Like the post-op nurses, they're still coming out of anesthesia. Okay? We take these measurements in the post-op. They're immediately following surgery. Okay? Basically, we really want to know what they are doing, what's their new baseline following surgery. Are they super low on hemoglobin? Do we need to give them blood? Did we cause acute kidney injury with their creatinine above 2? Okay. After severe trauma or major sepsis, okay, we add on fibrinogen. Coag and ABG are really not negotiable. So CBC, CMP, Coag, and AGG are normally what we do all the time for post-op trauma patients and major sepsis patients. Okay. For signs of coagulation disruption, okay, the things that we look for. So prolonged clotting times, low platelet counts, and decreased fibrinogen levels. Those are 3 main characteristics that we see in those labs, which is why we order those labs, to see if we have a coagulation disruption. Okay? If we really wanted to know, we could use a TEG if you had a TEG machine available. I've only had a TEG once in my career, and it was here at BMC. It's very expensive. It's very expensive to maintain, so a lot of military hospitals might not have it. Hemoglobin threshold for blood transfusions for non-cardiac patients is 7. If their hemoglobin is below 7, we're going to transfuse, as long as the patient accepts it. Okay? If they are a cardiac patient, then most of the time, like a cardiopath, most of the time if their hemoglobin is sometimes even 9, but most of the time it's 8, their threshold is higher, okay? Because their heart already has a hard enough time circulating the hemoglobin and the oxygen, okay? So if their hemoglobin drops to 8, we normally will transfuse, okay? But gold standard for normal, healthy patients, well, I guess they're not healthy if their hemoglobin is less than 7, but you kind of get my point, right? Okay. Now, let's talk about fluid replacement, okay? These are 3 terms that you're going to see. Maintenance, replacement, and resuscitation, okay? Knowing the difference between these is super, super, super important, okay? These are when words matter. So, you have a patient, they're in pre-op, they're just not eating, you have them on maintenance, okay? They don't have really extensive, extrinsic losses. Okay, so what's the rate? 30 mLs per day. Okay? So these are people who are just waiting for surgery, but they're NPO. Most of the time we give them D5, half normal saline, with a little bit of potassium in them. Okay? These are our post-op patients who have an ileus, who they're just not eating, they're still up and walking around, they're not septic, everything else is good, but they're just not ready to eat yet, they're not ready to drink yet. We put them on maintenance. Okay? Now, replacement. Think maintenance plus. Okay? These are your people who have diarrhea, who have vomiting, who have drains in their belly and we're pulling fluid out. Okay? If they have more fluid out from another source than just urine, we have to do replacement, which is their maintenance, 30 milliliters per kilogram per day, plus whatever how much they're coming out. So if they have an NG tube out, they have 600 milliliters losses from that NG tube. Okay, we divide that per the 24 hours and we add that to the maintenance. Does that make sense? Okay. Resuscitation is its own thing in itself. Okay? Resuscitation is a patient is in acute distress. Okay? They are really sick. They are bleeding out in front of you. They are septic as shit. right? These are, if they are dying in front of you, they are in resuscitation. Okay, they are really hypotensive, really tachycardic. The rate can vary. Okay, we're still going to go off of this maintenance, but really it's like if they're bleeding out in front of us, I don't care. Like I'm going to put in 1 unit as fast as possible. There is no real rate. Does that make sense? Yeah? Couple head nods. Okay. Main key points is if blood is out, you put blood in. Okay? If they're bleeding out in front of you, don't give them LR. Don't give them normal saline. You're giving them blood. If they're septic or have any other hypovolemic causes, they're severely dehydrated. Okay? We're going to give LR, NS, plasma light, and then eventually albumin. Okay? But mainly those crystalloids. Any questions on this? Okay. I would know maintenance, D5 replacement, mainly LR. Okay. We only use G5 or D5W or whatever dextrose. We only do in maintenance. If we're in replacement or resuscitation, we're not using anything with dextrose in it. Okay? So if you have a test question and we're talking about maintenance, okay? Maintenance is the only one that gets dextrose. If we're talking to you about or asking you about replacement or resuscitation, the test answer will never include dextrose. Okay. Sometimes we want it warmed. Okay, either saline or lactated ringers. We have to be very careful with normal saline. Lactated ringer is actually more of a gold standard now. Okay, because normal saline, if we give a lot, we can actually cause a hypercaloric metabolic acidosis. Okay. So normally we do LR. And I missed that. That should be maintenance and or resuscitation. Or, no, this is resuscitation. Yeah, never mind. Sorry. I had it right. This is resuscitation. Blood, if we're doing sepsis or any other hypovolemic, we're doing normal saline or lactated bringers, but again, lactated bringers is more standard. Okay? Alright. Yes.
I'm just a little confused when you said you were talking about replacement. You said maintenance plus whatever they're losing.
Yes.
So, but then you said like no dextrose.
For the rate.
Okay.
That's for the rate. Not the type of fluid, but the rate of the fluid.
Can you explain?
So, if we have somebody who they have enough extrinsic losses that they're needing to have above their normal maintenance rate, normally we will switch back to lactated ringers until they're back to their maintenance state. Okay? Does that make sense? So I know I say maintenance plus, that means like the rate of maintenance plus whatever they lost. It doesn't mean that we're actually going to change the fluid if we have to, if they one day start putting out a lot of their NG or they're having massive amounts of diarrhea, we're going to change their fluid from a dextrose base to a lactated ringer until that situation is resolved, and then we can put them back on the dextrose fluid for their maintenance when they get to that point in their health. Does that make sense? Yeah? Yes? Any more yeses? Any other questions on this? Okay, so when I say dextrose, it's just the type. Okay. Alright, crystalloids, kind of already talked about this. LR, NS, G5 half, basically sugar water. We use it for maintenance. We add the 20K to prevent hypokalemia. Sometimes we do both. Not very often though. Not very often. I won't ask that. Okay, that's just, if you go on the floor, sometimes we'll have different things running depending on what the patient needs, but for you guys, what I just said is what we're gonna do, okay? All right, really good charts, really good information, but I'm not going to test you what type of electrolytes are in each bag of fluids, okay? This is really good baseline information as to why we do what we do, like why LR is better than NS. So when we look over at the sodium and chloride in LR, okay, what is our normal body sodium level? (135 to 145). Okay, 130, right in the middle. Great. What is our chloride? 100 to 110. We have 109 chlorides in LR. That is very, very close to our body's physiological status. Okay? Versus when we give NS, that sodium is really high. Okay? If our normal is 145, the amount of sodium per liter is 154. Okay? And chloride as well. That's a lot of extra chloride and a lot of extra sodium. Okay, this is why NS is falling out of favor. Okay? Alright. 23-year-old female presents the emergency department with nausea, vomiting, diarrhea for 48 hours. Heart rate is 145, systolic blood pressure of 85. She is tachypnic, 23, but is oxygenating well on room air, 97%. Her GCS is 14, -1 for confusion. Her pupils are 3 millimeters equal, round and reactive. Her cap refills greater than 2 seconds. Which of the following intravenous fluid prescriptions is most likely to be utilized initially in this patient? Is she tachycardic? Yes. Is she hypotensive? Yes. Is she confused?
Yes.
Is she super confused? Is she comatose? Is she close to comatose? So what class of hypovolemic shock is she in? 3. Okay, now 145 is a little high, but her body's still compensating it with that GCS. I will be better in terms of, on the test, it will only be like between 120 and 130. Okay? But so, if she's in class 3 hypovolemic shock, where are we at? Who wants replacement? Who wants resuscitation? Anybody for maintenance? Anybody want to give her nutritional support? Anybody want to seek an adult? Okay, fair? Alright. So I would say because she's in a state of class 3 shock, like she's already shocky, okay? This is when you kind of have the beginning pucker effect. You walk in, she's sick. She does not look good. She's probably pale. Okay, she's breathing fast. She's tachycardic. She does not look good. Okay? Resuscitation. You have to resuscitate first. Okay? Once we resuscitate her and get her vitals back to a normal level, then we can start going into replacement. And then into maintenance. Okay? But this one, absolutely, we have to resuscitate her. Yes.
On the chart, you have like class 3 is decreased, class 4 is severely decreased blood pressure. Like, where would this fall? Decreased or severe decreased blood pressure?
Well, what is a normal blood pressure?
20 over 80.
Okay. So, for a 23-year-old, you think a blood pressure, a systolic blood pressure of 85.
I think that's severely decreased.
Severe.
It just says she's class 3, so.
Yes. Because her body is still compensating. Her body is still able to put blood to her brain. She is on the verge of going to a class 4. Like I said, in the test it will be very clear as to which it'll fall within those parameters. I didn't catch this on my review. But she's really class 3, class 4. Either way, you're going to resuscitate. Yes.
It sounds like you were kind of talking that it's like maintenance, replacement, resuscitation, but it doesn't sound like it should be like that. Within is they're, at a baseline, usually people there, and resuscitation is through this patient.
Mhm.
But then replacement, wouldn't that be you have them stabilized, but now they're leaking somewhere somehow, and then they need more of that? So like, if they're
But
class-
their body is still physiologically compensating. They're not in any shock state whatsoever.
Yeah, so it wouldn't be, if this person was just a regular, like the low end of class 3, they wouldn't be in replacement, they would still be in resuscitation.
Absolutely. Yeah, this is absolutely resuscitation.
Or even if they were in class 2, would they still be in resuscitation versus replacement?
If she looked like this, yes. Yeah. If we have to get her back to a normal physiological state in order to be either a maintenance or replacement. Okay? If they are at all physiologically abnormal, then we can't really we have to resuscitate. Okay? Does that make sense? Okay. What time is it? 1:15. When did we start? 35? Okay. Who's my break timer? Just yell at me when we have to stop. Okay. Resuscitation, some MTP. Has everybody heard of MTP? Massive Transfusion Protocol. All of us in the military should have heard this at least sometime, once or another. Okay? This is normally starting off with 6 units of packed red blood cells. Okay? Protocols do change from hospital to hospital, but for the most part, it normally means we are giving 6 or more units of blood. Okay? Most of the time, we are trying to combat the lethal triad of hypothermia, acidosis, and coagulopathy, meaning they're not clotting. Okay? This is really important. Okay? If we give 1 unit of packed red blood cells, their hemoglobin should rise by 1. Okay, so their hemoglobin is 6. We give them 1 unit of packed red blood cells, their hemoglobin should go to 7. That is the normal exchange rate. Okay? Historically, we would give like 2 liters of LR, like EMS. That is no longer the case. Okay? Now, as long as those EMS people have blood on their ambulances, they will do as much as they can if they don't. But as soon as they hit the ER doors, we are no longer giving them fluid, we're giving them blood. Okay? Has everybody heard of the 1:1:1 ratio? Raise your hand if you have not. Okay, a few. So basically, when we are giving blood products in a component strategy, okay, this is packed red blood cells, FFP, platelets, basically the kind of what they have here. So packed red blood cells, plasma, and platelets. Okay? When we are giving components, this does not include whole blood, but when we're giving component therapy, we try to do a ratio of, if we give 1 unit of packed red, we give 1 unit of plasma. And then 1 unit of platelets. Most of the time. Okay? That is the golden rule. But now, like, the gold standard is whole blood. Okay? Low titer O, whole blood. That is the gold standard. Okay? That has everything in it. That has your plasma, your FFP, all of your clotting factors. Okay? That's the gold standard. Alright. O-negative packed red blood cells, when we're using component therapies, really the preferred over any other type of packed reds. Okay? If we have to give O positive, most likely save that for a male. Try not to give it to any childbearing female or females of childbearing age. Why? I heard RH negative, RH positive stuff. Yep. Okay. We give O positive blood to an RH negative female, we kind of convert them, and it just leads to bad things. Okay. So if you have to, you have that discussion with that patient to say, hey, in the future, if you have kids, you may have issues, but try to save the O positive for males and the O negatives for females if you have to choose. Okay? Whole blood. Okay, we have walking donors. Normally the low titer O is used frequently. Fresh frozen plasma, it's frozen, so you need time to thaw it. Keep that in the back of your mind. But it has the clotting factor, it takes about 30 minutes to thaw. When you use platelets, it's technically you get 6 bags of platelets equals 1 unit of platelets. Okay? Generally, we reserve the platelets because it is super hard to get. So any patient that's less than 50, 50,000 platelet count. Okay. You'll talk about more of that when you get to your hematology class. But a lot of times, if the platelet count's that low, they're at risk of spontaneous bleeding, and the lower they go, like 20K, 10K, the risk of spontaneous bleeding is really, really high. So around 50, it's like they get a paper cut. They just don't have the clotting factors to even help clot that. Okay, and 1 unit of platelets can rise about 25,000. So 6 bags, 1 unit can raise 50 to 75. Does that make sense? Okay. All right. Other fluids. If you've heard of Hexten, get that out of your brain. It's old. We don't use it. Military doesn't use it. If you use it in a unit, don't tell me. Awful. Very dirty. Don't do it. Kills people. Albumin. These are our colloids. Okay. We do not use this for acute resuscitation. These are for people, burn patients, septic patients, who we've given so much fluid to help raise up their blood pressure that they're now third spacing. Does everybody remember what third spacing is? Okay, it leaks out of their actual vasculature and you look like the Michelin Man. Okay? We use albumin to help give them fluids, but the proteins are still big. They don't leak out of those leaky vessels. So it helps increase the intravascular pressure. Okay? But doesn't third space. So it really helps try to pull that third spacing back. Okay, so if you have a patient who you really need to give fluid to, but the more fluid, the more crystalloid you give them, the more just Michelin Man's them, you can try a colloid, like an albumin, to try to help prevent that. Okay? And then hypertonic saline, we'll talk more about this when we get to head injuries and trauma. There's only a couple reasons why we give hypertonic saline. These are 3% sodium. Okay, so if you think 0.9% sodium has 154 millimoles of sodium, 3% is a lot. Okay, we give this in very, very small increments, pretty much no more than 250 milliliters in a bolus. Okay, if they're really severely natremic, then we can give this if they're actively seizing. Okay, or if they have a head injury and we are trying to decrease the brain pressure, the intracranial pressure, we can give this as well, but we'll talk about that later. But just know that hypertonic saline is something that we use in only very, very, very specific cases. All right, other additional fluids, just know they exist. DDAVP. Okay, if you have somebody who's really struggling with clotting, but you get their INR, you get their platelet count, everything seems a little bit normal. Okay, you can give them DDAVP and it'll help release that von Willebrand factor and help kind of help them clot. Okay, cryoprecipitate has a bunch of those clotting factors: von Willebrand, fibrinogen, fibronectin, factors 8 and 13. Basically, a lot of factors. Okay, if they're low, we can give them this, and it'll help boost them. So like their platelets are fine, but they're still oozy. We can give this. Aminocarboic acid, just another antifibrinolytic, helps strengthen clots. Really only used for cardiac procedures. I will not test you on it. Excuse me. Tranexamic acid, TXA. This is one that you should know. You should remember. I may test you on it. Okay. TXA is what we use now in all trauma patients that come in with any significant amount of bleeding who are shocky. Okay, it's an antifibrinolytic agent. It strengthens the clot, but we must give it within 3 hours of injury. So if the patient comes in at 3.5 hours or 4 hours, we're not giving it. Okay, the risk, the research has shown that the risk of bad outcomes is too high. All right, 75-year-old lady is admitted for planned elective knee replacement surgery the next day. She has a long-standing hypertension. through which she takes in a load of pain. She has no other medical problems. Laboratory parameters are within normal limits. She was placed on intravenous fluids, and her weight at admission was 80 kilograms, which is the following is correct choice and rate per hour. Who thinks 1? Okay, who thinks 2? Okay, who thinks 3? Who thinks 4? Who thinks 5? Okay. 23.4% ceiling. What is that? That's hypertonic. Do we give it in a patient like this? Does she have a blood or head injury, or does she have, no, okay? 3% saline. Hypertonic. What is the rate per hour for maintenance? 30 milliliters per kg per day. Okay? She's 80 kgs. Who's going to do that mental math for me? We're going to do 100. So that's how you do that. Okay? You read that entire thing, and all you needed was she was 80 kilograms. Okay, don't skip. Don't not read the questions. But yeah.
Would it not be the D5W plus half normal saline?
That would be the preferred. Okay. But she's also pre-op, or no? Yeah, she's pre-op. So we normally don't do dextrose for pre-op, but I'm not going to test you on that. Which is why we normally do, and saline is really not even the gold line either way. It would probably be LR. But out of these options, this is the most appropriate. Okay, but yes, you're right. Okay. All right. You guys want a break? 10-minute break. Okay, 10-minute break. Maybe 9-minute break. Is that asking too much? Are willing and able. Willing is a big part of this, and able to hold a urine collection, a urinal, okay? We can do that, but we have to educate the patient on really, if we are trying to get strict ins and outs, okay? How much are they taking in by mouth? How much are they urinating? Okay? We have to educate that patient, hey, don't dump this in the toilet. The nurse is going to come in every so often and document how much urine you output, okay? If they are unable, they have dementia, they have a broken arm, they can't comprehend, or they're kind of confused still from a TV, whatever, we put in a Foley. Okay? Everybody know what a Foley is? Urinary catheter. Okay? This is just a funny depiction of this is good. Make sure it's all the way in. That hurts. Okay? Alright. Complications. Okay, we can give people UTIs, which can progress to urosepsis. So we have to do it under sterile procedure. Okay? If you don't know how to do it correctly, don't offer to do it. Okay? You will kill people from urosepsis if you do this in a dirty fashion. Okay? And urethral injury. There's a lot of times, if it's a traumatic Foley, okay, we'll actually have blood in the urine. We have to figure out where that blood is coming from. Oliguria, so low urine is the most reliable sign of moderate shock. Okay, this is the most reliable, standardized. If your kidneys start to produce less urine, your body is not able to compensate. Okay, someone who is extremely fit, right, who their resting heart rate is 40, tachycardia may be 80 for them. Super tachycardia may be 100 for them. It's not reliable. Okay. So we really watch urine output. Okay, in ICUs we actually record the urine output every hour, and we get pissed if the nurses don't do it and don't record it, because we're actually sitting at the computer watching the trend per hour. You know, do we need to decrease their rate? We need to increase their rate. We need to switch it to something else. Okay, if they go from 0.5 mils per kg per hour, and all of a sudden they go up to 3, right? That may mean that their trauma, their head trauma, is now translating into diabetes insipidus or something with SADH, right? So trending per hour is extremely important. All right, let's move into electrolyte disorders. Only going to really talk about two-ish. Okay, sodium being the biggest one. Okay, what we are measuring is serum. We're not measuring total body. Okay, normal range 135 to 145. Okay, so let's talk about low sodium, hyponatremia. Okay, this is a sodium concentration in the serum less than 135. Okay, if they're 134, 133, it's really not that bad. Once we start to get into 120s or below, or even 130 and below, okay, really starts to reflect a water imbalance relative to the sodium. Okay, something is happening that is making our kidneys retain water. Where water goes, sodium goes. Okay, the body is trying to compensate for that low sodium. Does that make sense? Okay. Most common electrolyte abnormality in hospitalized patients, most of the time, it's too much water. Okay? It's weird. So you have somebody who we have given a lot of free water to, or we've given a lot of some sort of fluid to, we can actually drop their sodium because of those shifts. Okay? So if we pump someone full of fluids, okay, their body's not compensating, it's a weird imbalance. Okay? Know this chart, it's an important chart. Know it because it has a great things for phase 2, but I'm not going to test from this chart. Okay? Goes through, if you have hyponatremia, the serum osmolality, if it's normal, low, high, and kind of what your differential diagnoses could be. Okay. All right. So you have hyponatremia. What are your signs and symptoms? Hypotonicity, okay? Mainly neurological. Really relates to brain edema because that body shift, that fluid shift. Okay? If they're chronically low, could be asymptomatic because their body's compensated for it. Normally acute disease progresses over hours to days, may present severely. So mild, 130 to 134. You may have gait disturbances, falls, fractures. You may have some nausea, lethargy, disorientation. You may have a headache, but nothing too great. Okay, flu-like symptoms. Severe hyponatremia, though, less than 120. Okay, seizures, coma, herniation, death. Bad. Okay. Rapid decrease is a very big component of this. Okay, if they're chronically below 120, they may just be really confused, they look drunk, they're not, like, they're really unbalanced. It's very, like, it's a critical finding, but they may be, because it's chronic, right? We see these a lot in our chronic alcoholics. There's, you know, they're really lethargic, they are really disoriented, but it's that rapid decrease that really causes the seizures, comas, herniation, and death. Okay? So what do we want to know? Any new medications? There are medications that cause the shifts of sodium. Any history of chronic alcohol abuse or dependency? Okay? Are they drinking a lot of water? Are they, for polydipsia, are they newly diabetic? Are they only drinking water because they're anorexic? Okay, they're not taking in any other nutrients. Are we giving them IV fluids at a high rate? We're not being judicious. We're just giving them fluids. Okay? Or changes in fluid output. Okay, this is a little counterintuitive. Okay, but think about rapid changes of your body is expelling fluid, but you're not necessarily, the concentration is low. Okay, so vomiting, diarrhea, ostomy output, which is diarrhea, polyuria, oliguria, sensible losses. There's as long as you have that water imbalance relative to sodium, okay, so sodium is low, water is high, then you're gonna have some issues. You're gonna be hyponatremic, okay? We wanna know volume status, so are they hypovolemic, euvolemic, hypovolemic? Again, are they dehydrated? But again, not really a measure of volume status. What do we want to look at? We want to look at their serum electrolytes, okay? We want to know that FeNO. Okay, we want to know creatinine, BUN. We want to know osmolality, so urine osmolality, serum osmolality. Okay. We may want to consider thyroid and adrenal functions. This can be caused by other endocrine type disorders. Okay. What are we going to do? How are we going to treat it? We found it, now how are we going to treat it? So, severe hyponatremia, you got to hospitalize them. This is not something you can do on an outpatient basis. Okay? We're going to give them a nephrology consult, so the kidney doctors, not urology. What is the difference between urology and nephrology? Surgery. Yep, nephrology does not do surgery. They are the kidney doctors, versus urology are the surgeons who do everything. Okay, we want to monitor their fluid balance and weight. They get a daily weight. Okay, we want to look through the medications and do a deep dive into what they're taking. Maybe we're giving them something that is causing this hyponatremia. If they have an acute seizure, okay, they are in the ER, they are acutely seizing, we can give 100 milliliters of 3% normal of hypertonic saline to try to raise that sodium up just enough without giving them a bunch of fluid, right, because they're too high of fluid. We can do that over 10 minutes until we stop the seizure, okay? But the main goal is to correct it slowly, okay? We only do the bolus over 10 minutes if they are acutely seizing from a low hyponatremia, okay? If they're just seizing, you still don't give them hypertonic saline. You have to know that they have a low sodium, which is causing the seizure. Okay? Don't let me hear that you had a patient in the ER and they were seizing and you just gave them hypertonic saline. Don't do that. Okay? You have to prove that they are hyponatremic and seizing to give that 3% bolus. Okay? The main goal is over 24 hours. We want to decrease 4 to 6 milliequivalent per liter per day. Okay. Rapid, we want to increase by 4 to 6 a day. If we rapidly correct it, okay, we give way too much normal or hypertonic saline, or we go like 10 milliliters, 50 milliequivalents per day, that could cause demyelination of the brain and bad news. Okay, so this is why we go slow. Okay. If they're able to drink, right, they're too fluid overloaded. So we put them on a fluid restriction to try to balance out that sodium. So we bring down that fluid to try to even out that sodium. Does that make sense? Okay. They don't like it. Nobody likes having a free water restriction. We only give them like a liter a day. It's crazy. They don't like it. Okay. For post-op patients, we do the same thing. They just gave them too much IV fluids during their case. We just put them on a little fluid restriction. We try not to replace water. Okay. And we just track their urine output and their serum sodium. Okay. Any questions on hyponatremia? Okay, let's switch over to hypernatremia. Okay. So this is a serum greater than 145. Okay. All patients with hypernatremia have hyperosmolality. Okay. So your fluid's low. Sodium high. Okay. So your concentration of your fluid is super high. You have low fluid. So the problem is they don't have enough water. They are dehydrated. They are losing fluid, whether DI, SIDH, they're vomiting, they have burns. Okay, normally first symptom is thirst. Okay, but not enough water. What are they going to look like? Kind of the same thing. Okay, they're lethargic, they're irritable, they're weak. Those are early signs. Once you start getting into hyperthermia, delirium, seizures, those are severe late signs. Coma is the coma and death are the last signs. Okay, because it takes time for those waters to shift, those the balances to shift. It may not present right away. Severe hypernatremia is greater than 158. And with acute hyperosmolality, so normal is 275 to 295. If you're 320 to 330, you're going to be pretty somnolent and confused. Okay, you're really concentrated. Even more concentrated, you're going to have coma, respiratory arrest, and death. Okay, these are why we teach these, because it is super important to try to catch these before they get to these severe cases. Okay, because both ends of the extremes end in death. All right, how are we going to find it? So, here it says osmolality greater than 400. Sure, but really anything above that 295, I'll accept. Okay. The normal. Actually, I don't like that. I should have changed that. Hold on. I did not catch that on my reread. So let's say change this to 320. 400 is 320. Okay, anything above 320. Okay, you're going to have non-renal losses. Hypernatremia will develop if water intake falls behind. Okay. Progressive water volume depletion. Okay, your sugar is really high. You're going to cause hypernatremia. Okay. In some cases, when your osmolality is actually decreased, very rare, you're going to only be looking really at central DI and neurogenic DI. Okay? So when you have hypernatremia with a very dilute urine, okay, that's DI. The only DI is really the only case in which you have a hypoosmolality with hypernatremia. Okay? So high sodium, low concentration, DI. Okay, it can be caused by a bunch of different things. This is the only case in which you have a low osmolality, low concentration. Okay. All right. Replace the free water. Okay, so hyponatremia, you're going to fluid restrict. Hypernatremia, you're trying to get free water. Okay, oral is best. If you're going to use IV, we try to go with a hypotonic fluid like D5W. Not D5 saline, D5W. We don't want to give them more sodium with any type of saline. So we go free water. Okay. Again, we go slow. Rapid correction can cause cerebral edema and permanent severe neurological impairment. Okay. Kind of just what we talked about. If you have hypernatremia with hypovolemia, you want to restore that to euvolemia, so we want to give them fluid. Okay. Hypernatremia with euvolemia, you're just kind of given water, a little bit of dextrose fluid to try to drive out that sodium. Okay. If you're high sodium and high volume, you're going to just treat with D5W to try to decrease that osmolality. Okay. We may, in this instance, give a loop diuretic to try to push out that sodium. Okay. Very severe cases, we may have to resort to dialysis to try to really filter out that sodium if we can't get it just by treatment alone. Alright, so how do we calculate how much water they need? They're hypernutrient, they're high sodium, okay? And we need to give them water. What is the calculation? Okay? When you're, if you do any rounds in the ICU, this is one we do daily. For anybody who's in a hypernatremic state. You take their current total body weight. Okay, this is why daily weights are really important. We take their serum sodium, minus 140, divide by 140. Okay, that'll give you a number. And we just basically, it'll be like, say, 1,000. We divide that by 24 hours, or by how many hours they're going to be awake, let's say 8. And those are the amount of, like, we'll give 200 milliliters per hour of free water to try to make up for that free water deficit. Does that make sense? Yeah, a couple head shakes. Okay. I don't think I'm going to ask you to actually calculate free water. Okay? But I want you to know what free water is. Okay? When we're correcting sodium, we don't want to go more than 10 milliequivalents per day. Okay? We want to try to get it at least down to 140. And we will do electrolyte labs every 2 to 8 hours, depending on how bad it is. If they're in the ICU, we may actually do it every hour. Okay? All right, any questions on free water? Okay. Again, urine output. There's a theme. Urine output. Best indicators of fluid volume status. Okay. In a post-op patient with a urinary output that is decreased, okay, so their body is trying to hold on to fluid because we did not give them enough during the case, meaning they're super concentrated because they're dehydrated, we treat with bolus, IVF, and not diuretics. Okay? Alright. The biggest thing is when we do free water calculations or any type of fluid resuscitation, we're not just going on formulas alone. Okay? You don't just do the maintenance fluid rate of 30 mils per kg per hour, right? And just leave them on that for weeks or days. We're constantly reassessing their urine output, okay, which is why urine output is so important. We're reassessing that, and if it dips, even if 300 or let's say 100 milliliters per hour is their maintenance rate based on their weight. If they're low urine output, we're going to increase it, maybe to 125, maybe to 150. Okay? If they're really producing urine, we may drop it to 95, we may drop it to 75. Okay? So it's not necessarily, we use that rate, that calculation for rate as the initial, but we still go off of the patient's physiological status and like their urine output to actually decide if we need to go up or down on their maintenance fluid or resuscitation or anything like that. Okay, does that make sense? Okay, it's like treat the patient, not monitor. Everybody's heard that phrase? Okay, all right. Couple slides on potassium. So normal potassium is around 4. That's where our body likes it. Anything below 4 we can consider as hypokalemic. Okay. Decreased by GI losses, vomiting, diarrhea. If we give excessive diuretic administration, okay, prolonged malnutrition, prolonged alkalosis, okay. You're going to have decreased muscle contractility, diaphragm paralysis. What are you going to see on EKG? So if anybody has a weird potassium that is not 4, you should always get an EKG. Okay? They come back with a potassium of 3, potassium of 2, potassium of 6. Always get an EKG. You have to prove that they're being symptomatic. So on those EKGs, you're going to use a flattened inverted T waves. So flat. If it's If it's flat, we give more, but realistically, we're just gonna give them potassium, IV or PO, if they can take a PO, and we're gonna just monitor depending on how bad it is. If they come in and their potassium's a 3, and we're wanting to watch their belly stuff, potassium, the intestinal paresthesia, intestinal peristalsis really wants potassium and magnesium to be like really normal for really good peristalsis. So if we have a post-op patient who's kind of on the verge of an ileus, which we'll talk about, basically it's like a shock to the intestines since we touched them. But if it's less than 4, we will give them supplemental potassium to try to make that normal range, to try to put their body in as much a U state, right, a normal state, in order for their body physiological like things to continue. Okay, if you're giving patients potassium, and it just will not go up, make sure you are also treating their hypomagnesemia. Okay. Most of the time, those two go hand in hand. So a lot of times when we give potassium, we will also give magnesium. Yeah.
I think we talked about like 3.5 to 5 finger range is for like more specific to surgery to just
Yeah.
have a more
Because if we are really having a patient with an ileus, we're not like even at 3.5, I'll give 20 or 40 milliequivalents of potassium a day. We really want to try to meet that 4. All right, hyperkalemia, so greater than 4, often caused by renal disease. Okay, you have a test that comes back with a potassium of like anything above 5.5, I would repeat the lab to make sure it's not hemolyzed. Okay, repeat the lab just to make sure that it is actually that level. If it is that level, let me give an EKG. If we have peaked T waves, flattened P waves, peaked T waves, like you see here, okay, that is symptomatic. Okay, so if they are 6.5 or symptomatic, so if they're 5 and symptomatic, 4.5 and symptomatic, okay, we will do initial treatment. The first, always first, is that calcium gluconate. Okay. Anytime we are medication treating hyperkalemia, you have to do calcium gluconate first. We have to stabilize that cardiac membrane, and then we can give that that sugar and insulin to drive that potassium back into the cell. Okay, and then we can give albuterol as like that 4th stage if we need it. Most of the time, the calcium, sugar, and insulin are all that's needed. You may have to do it numerous times, but always calcium first. Okay, which metabolic disorder is often associated with hypokalemia? Alkalosis. You're gonna have hypermagnesium with hypo.
No, reverse.
Hypomagnesium, right? If potassium is low, magnesium is also probably low. Okay. All right. Vascular access. We have peripheral lines, we have interosseous lines, we have central lines. Okay. Those are how the first 3 are how we get things or fluid back into a patient. Okay. An art line, an arterial line, if we do not give through that line. This is only a line for measurements. For continuous blood pressure monitoring, we do not infuse fluids. Okay? Depending on what we need to give to the patient and how much will depend on which one we pick. Okay? So, peripheral IVs. If they are a trauma patient, we at least try to do a 20 or greater. 18, 16, 14s are best. At least a 20 only because if we have to do CT with contrast, anything great or anything lower than a 20 gauge, the contrast doesn't doesn't work. Okay. Where are we gonna put it? Normally our ACs, we can do our hands, okay? When we do the IV lab, you guys will practice on all those. There's some that, some nurses that are really good on the forearms, depending on how great the patient's vasculature is. But normally it's the AC on initial contact, okay? KVO, keeping the vein open, so this is just, you basically close off the line and have it just a small drip just to keep the line open. If you see TKOs to keep open, same thing. Okay, you just have enough, it's not like an actual rate. We're not giving fluid in order to, for maintenance or for resuscitation or for replacement. This is just a small drip through the line in order to keep that catheter and vein open. Okay, it is not adequate for volume hydration. Okay. If you see HEP lock or saline lock, okay, not hooked up to a bag at all. There's a little tiny thing that, or it's locked. You may have heparin through it. You may have, just a lock on it. Just basically, you have the IV, but there's nothing going through it. Okay, and a venous vein, saphenous vein cut down. We really don't talk about those here. You may see them at phase 2. They're really for sick patients. In somebody who is vascularly collapsed and we can't get a line anywhere, okay? If you have a surgeon or an ER doc who are really good at them, then they can actually cut through the skin, cut down into a vein, and put the catheter straight into the vein. Not really done very much anymore because we have advances in like central lines and that kind of thing, and IOs. But speaking about IOs, so IOs are next. So interosseous infusions, okay? These are the needles that go into the bone. These are the sites in which we put them, okay? Proximal humerus, proximal tibia, distal tibia. Sternum, I know is being taught in like TCCC. I do not agree with it at all. Okay, you basically have 5 1-inch long, needles into your sternum. Say that patient needs to have CPR. What are you gonna do? Not great. So I don't recommend the sternum. Sternum will never be the answer unless it's which one do we not do? Okay, so proximal humerus, proximal tibia, distal tibia. This is only a bridge to us actually getting vascular access. Okay, this is someone who is coming into the ER. They are in, cardiovascular arrest, traumatic arrest. They do not have blood pumping, or they are so hypovolemic that we cannot get vascular access. We put an IO in to try and push meds and fluids through this medullary sinus in the bone in order to really try to give them any fluid. It actually is a pretty decent exchange rate. Like we can put a lot of fluid in there so that we can pump them up just enough, and then within a day or so, or within hours, we take that IO out and we put it back. Once we have vascular access, then we take the IO out. Okay. Contraindication. Don't put it in if there's a fracture in that bone. Kind of defeats the purpose of the medullary sinus. Okay, it will lead to compartment syndrome in that extremity. Okay, so if the bone, if the humerus or the tibia are broken, do not put it in those sites. It's just going to leak out and cause compartment syndrome. But you can put it in if there's burns. We try not to put it in if it's over cellulitis. Pick a different spot. But the absolute contraindication is fracture. Central lines. Okay, we have a couple of different central lines. We have a cordis, which is a single lumen, meaning that there's one floor through the entire thing. We have a triple lumen. We have double lumens. We have central lines that will handle the pressure of dialysis machines, called the trialysis. Okay, it just depends on what we're trying to aim for. If we are doing trauma, normally we will do a cordis because we want that large bore. This is like a 12, or it's a huge bore. They're probably a 12 gauge. type of thing. So if you think 18 to 14 IVs are big, right? A central line is much, much bigger. And we can administer a significant amount of fluid to that patient through that one bore very, very, very quickly. Okay, like we can give a unit of blood within minutes. Versus if we try to do it through a 20 gauge, it's going to take probably twice to 3 times, maybe even 4 times as long. Okay. When we want a triple lumen, those are basically 3 lines that enter the body as one. Okay, I'll see if I can find, I think we play with these in your EM lab. But basically we use that for people who are septic, who we need to give multiple medications to. So like say you're on antibiotics, pressors, and you're on multiple pressors, right? And you need multiple lines into a patient. You can do it from one location. So triple lumen versus a 1 lumen. Okay? We use it for parenteral nutrition. We can use it for other nutrition, which we'll talk about. A lot of times there are medications, a lot of pressors and TPN that are very caustic to our blood vessels, our peripheral blood vessels. So we really want to have a central line. Okay. When we have to do pacing, transvenous pacing, and dialysis until we can get the trialysis into the patient, we can use these. Okay. What are the complications? So, where are the 3 sites for central lines? Subclavian, IJ, and femoral. Okay. So, if our complication of a pneumothorax, which 2 sites is it going to be at? Subclavian and IJs, right? You don't need a chest x-ray. You don't need to prove that you haven't done a pneumothorax on a femoral. Okay? But if you do an IJ or an IJ or subclavian, you have to get that chest x-ray to make sure that you didn't cause a pneumothorax. Arterial puncture is also very common. You kind of go back wall if the artery is below it, okay? So like on this guy, I'll show it on the other one in a second, that's the vein, that's the artery. You can see how if you don't gauge it right and don't use your ultrasound right, you're going to back wall the vein and go straight into the artery. Okay? So on this one you have vein, you have artery, this is the top. If you go down and back wall the vein, you're already into the artery. That's how that happens. Okay? Which is why we try to get views that they're not right on top of each other, right? Sterilization techniques are extremely important, okay? The only time it's really not is when the patient is crashing for trauma or if they're already septic, right? And we are trying to preserve life. We will put them in as fast as humanly possible to try to give them blood or fluid, and then exchange them for sterile. So we actually then, once they're stabilized in a different spot, sterilely, we will put another one in and take out the dirty line. Okay, but that really is only in extremis. Otherwise, we should be doing like full gown, full mace, or full face mask, okay, full sterile technique. And then we remove the catheter as soon as it is no longer needed. Okay, these are the sites, subclavian internal, jugular femoral, external jugular, not really. Cephalic veins, not really. If we're going to do cephalic veins, we're more likely going to go with a PIC, which we'll talk about next. But these 3 sites are the most common. Okay? In the PowerPoint, you have this video. I unfortunately did not check it to see if it is still active. To go over the Sellinger technique. Basically, when you see Sellinger, just think insertion of a line, whether it's a catheter or a chest tube, it's whatever, over a wire. Okay? Sellinger technique is just insertion of a tube over a wire. Okay? Alright. PICCs. So peripherally inserted central catheters, they're called central catheters because the tip ends in the right atrium or just before the right atrium. Okay? But they start in the cephalic, in the upper arm. Okay? So they're very, very long lines. Normally you have to be PICC certified in order to do them. Okay? They're normally easy to care for, pretty easy to take care of. It avoids any complications of endothorax because the insertion point is all the way down in the arm. Infections, thrombosis of the line is super high risk of thrombosis within the length, because that's a long length. If there's not a lot of stuff going through it on an hourly basis, which sometimes we send people home on PICCs if they're only doing like antibiotics for 6 weeks, 8 weeks. Okay, they're only doing antibiotics for like 1 to 2 hours during the day. The rest of the time it's not in use. Okay, so the blood and the fluid, whatever's in that line, can thrombose and make it so that it's not usable. Okay. Arterial lines, there's only really 2 sites that we use: radial artery and femoral artery. Who can tell me what the Allen test is? Collateral circulation of the hands. Right? How do you do it?
Squeeze both sides.
So you can do it to yourself. I don't know if you can see. See, my hand's nice and pink. Okay? Closing off both my radial and my ulnar artery. Hopefully my hand is turning pale. Okay? Do you want to prove that you have radicular circulation through the ulna? You let go of your ulna and your hand should turn pink again. Okay? That means if when you put that art line in your radius, if it actually spasms off or you do so much trauma to the radial artery that it thromboses, you still have that collateral blood vessel to bring blood to your hand. If not, you don't put the art line in that radial artery. Okay? Because if that does induce a thrombosis of that radial artery, now you have an ischemic arm or ischemic hand. That's not good. That's a life limb eyesight, right? It's bad. So that's the Allen's test. 2 main reasons why we do it: continuous arterial blood pressure. These are way more sensitive than just a normal blood pressure of your arm. Okay? And then repeated arterial blood gases. We have somebody who is intubated, and we're constantly changing the ventilation settings, and we're, every hour we're getting an ABG. Instead of poking that radial artery every hour, we just put in an art line. Okay? The biggest thing, biggest hassle really is finding the transducer wire to go from the line to the machine, to the monitor. Alright, portable plants, just know that they exist really for chemotherapy, long-term antibiotics if they don't want to do a PICC. Sits underneath the skin, normally in the upper chest. Okay. Alright, GI tubes and nutrition, we're almost done. What types of tubes we have? Okay. We have NG tubes, nasal gastric tubes. Okay, those go in the nose. We have OG tubes, which I didn't put up here. We have enteric nutrition feeding tubes. Okay, that could be an NG tube, that could be an OG tube, that could be a G tube, a PEG tube. We'll go through them all. Total parenteral nutrition, TPN. That is liquid fluid that we put through an IV or a central line. Normally when the gut does not work. Okay? Biggest thing when we start nutrition is refeeding syndrome. It'll not be the last time you see that. Okay? You have somebody who is severely malnutrition, okay? And we start giving them food, any type of caloric input, that can actually drop their phosphate so low that they enter into a repeating syndrome and not do well. Okay? But if the gut works, we use it. We try to start feeding the gut as soon as humanly possible. Alright. NG, OG. So NG, OG. OG if they're intubated. Most of the time, if we still think they need to have some sort of nasal gastric or gastric suctioning, or if we're starting to feed the gut and they're going to be extubated, we'll switch to an OG or an NG. Okay. If we are actually trying to, they have an ileus, their intestines are not working, okay, they're nauseous, they're vomiting, we will put the NG in and put it to low intermittent wall suction. Not continuous, not high. Okay? This end of the tube sits in the belly, sits in the stomach, and if it's high or uncontinuous, it can actually attach itself to the wall of the stomach and cause it to erode through, causing a perforation. So, if you are sucking from that tube, low intermittent wall suction. Okay. Placement on ileus, we normally confirm placement with a KUB or a chest X-ray. Okay. Contraindications. If you have anybody who you suspect a basilar skull fracture or cribriform plate fracture, do not put anything in their nose. Okay? These nice little CT scans on the side here show what happens when that is done. Okay? That's an NG tube, or actually I think that's an OG tube in her brain. Not good. Don't do that. Okay? Like I said, complications, esophageal stomach injuries from it attaching to that wall. If we suck too much, we can cause hypokalemia, but unfortunately, we want to suck as much as we can out to relieve the nauseousness. So a lot of times we have to give them potassium in order to combat this. Okay? We have duodenal and jejunal, wow, nasoenteric tubes. Okay? These are tubes that normally are Domhoff tubes. Okay, they're very thin, they're flexible. We don't suck from these, we only give. Okay, this is for food only. Whereas the nasogastric and oral gastric tubes, we can do both. With the Domhoff, we only give. Okay, normally confirmed by KUB or chest X-ray. Okay, we want to make sure that that tip is past midline. Okay, this actually went back up and down. That's not what we want. That's actually in the lungs. That's in the trachea. Okay, everybody see that trachea? This one, I think is the only one that's correct because it goes down past and into the lung, or into the past it through caloric stenosis or caloric sphincter, caloric, sure. And then that one's just not far enough. Okay. We do this to anybody who can't eat, even if they're awake, they're delirious, they're demented. Okay, if they can't eat, we give them this and give them food. Okay, as long as we can give them, as long as we can use their gut, we can use that. Okay, long term, say somebody really has like esophageal cancer, or they have some sort of thing, they can't, they've had a neurological issue where they can't swallow anymore, or a neurodevelopmental issue that they can't swallow. We will put in either a PEG tube, which is a PERC tube. Okay, basically it's just a G tube that we put in by endoscopy. Okay. G tube, surgically done. We do it open. We do cut a little thing in their stomach, find the stomach, tack it up to the skin, put the tube in, close the skin. Okay. We can also do that with the jejunum. Normally that'll be rare cases. Say they just did a huge, like, we'll talk about Whipple's, but they took out a big portion of their duodenum, their big portion of their first small intestines. okay? They'll use the jejunum versus the duodenum or gastric even for that tube. We're trying to feed them post, like after that surgical site, so that food isn't touching those surgical sites. Okay? Feeding can often start either on day 1 or day 2, just depends on what their gut's doing. Okay? Liquid nutrition provides hydration and nutrition when people can't eat. Normally we want to calculate the normal basal metabolic rate. I'm not going to make you do that. If you want to see how NG, OG, Dow-Pop tubes are placed, you can watch that. Peripheral and total parenteral nutrition. So peripheral parenteral nutrition. Okay, that is nutrition that is being given by peripheral. Still vein. Okay, we don't do it very long. It's very caustic to the veins. Peripheral. If it's total parenteral nutrition, central line only. Okay, so we'll start PPN while we get the central line to then switch over to TPN. Okay? Total enteric nutrition. These are your tube feeds. Different than parenteral nutrition. Still liquid, but it goes into the gut. Do not give total enteric nutrition into an IV. Okay? We check electrolytes daily, weekly, albumin, free albumin, to see how well they're progressing. Okay. These are some indications for using TEN. Okay? Just know if they're not eating and if we can use the gut, we're going to use TEN. If they're not eating and we cannot use the gut, we're using TPN. Biggest thing to take away here for TPN, daily electrolytes for severe nutrition, malnutrition. Okay, we got to watch for that refeeding syndrome. If they are at severe risk, we may even do it multiple times a day. Okay. Anybody who's doing not for severe nutrition, then we'll do weekly electrolytes, lipid panel, and liver enzymes to make sure that we are not causing issues. Okay, 64-year-old male develops supraventricular arrhythmias after undergoing open heart surgery. Laboratory measurements indicate potassium levels of 6.7. After administering calcium, what is your next step?
Insulin. 3.
Anybody disagree with 3? Great. All right. Has anybody not seen a very critical patient before? Okay. Can be very, very scary. We talked about a lot of tubes, a lot of lines. This patient has an NG in their nose, they have an ET tube in their mouth, they have an ICE intracranial pressure monitor on their head, they have pulse ox, they have IV fluids going, they have meds going, lots of things, okay? This is not even that bad. Okay, so when you get to phase 2 and you get to these critical care patients, or even patients in the ER, right, getting ready to go, they may be a lot of things. Okay, if you're not used to that, start trying to get into that. Because the first time you see it, the smells, the sounds, the everything kind of just, it can get to you if you're not used to it. Okay?